Welcome to today's main SUD Learning Community webinar. Today we'll be hearing from Dr. Patrick Tolosky, and I forgot to double check on the pronunciation of your name,
You
so
got it. You got it.
hopefully I got that right. And Dr. Toby Nicholas on applying a harm reduction lens to PrEP prescribing. My name is Kristen with CCSME, and I'll be supporting today's webinar along with my colleague, Casey. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with the accreditation requirements and policies of ACCME through the joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. The opinions expressed by speakers in this webinar series are their own and do not represent a position of the state of Maine or CCSME. Recording and live stream transmission of this webinar without consent is not permitted. We will have a few minutes at the end of the presentation for questions and answers, so please hold any questions until that time, or you can place them in the chat as we go, so you don't forget your questions by the time we get to the end. Slides and materials from today's webinar will be sent out in the follow-up email. We'll also share the evaluation survey in the chat and in the follow-up email for the survey and certificate information. And with that, I will hand it off to Patrick for today's presentation. Thank you all for being here today.
Thanks so much, Kristen, and thank you for joining everyone. I was just going to do a quick introduction of myself and also let my companion, Toby, introduce himself as well. So I'm Patrick Tolosky, he, him pronouns. I'm a family medicine doctor, graduated from University of Massachusetts last summer, and now I'm in the Maine Health Leadership and Preventive Medicine Fellowship based out of Portland, and we work in various areas around Maine. And we've been doing some work learning about the HIV outbreak in Penobscot County and working with Dr. Stephen Rollins on developing some resources that we're going to share with you today. And yeah, I think that's it for me. Toby, do you want to introduce yourself?
Yep, I'm Toby Nicholson, UCM pronouns. I'm also a family medicine physician and preventive medicine fellow here at Maine Health and see patients in Gilman Clinic living with HIV and do a lot of PrEP prescribing as well. And coming to you from Gender Clinic here in Portland this morning. So appreciate the opportunity to talk to you.
Great. Thanks, Toby. All right, I'm just going to jump right in and get us started. So just to talk about some learning objectives today to set the stage. So we're going to talk about some of the fundamental clinical considerations for PrEP prescribing, both from an initial appointment and also in an ongoing manner, and talk about opportunities to really focus on a harm reduction framework and mindset to PrEP prescribing. So we'll get into more of those details. And we're also going to briefly highlight this document that Toby's been championing and I've been working on with him along with Dr. Stephen Rawlings from the Gilman Clinic that we're calling our PrEP Clinical Starter Guide, which is really a condensed document to highlight all of the major points about PrEP prescribing, both from a clinical lens in terms of labs to follow up, considerations, but also a harm reduction focus. And that guide we'll be planning to share with you all should be pretty much complete in the next 1 to 2 weeks or so. And so hoping that can be a good kind of point of care resource for folks. And also highlight some other kind of resources that folks could use for a deeper dive if they're interested in a deeper dive in PrEP. So this is just I'm not going to go through every single detail of this. Toby's going to go into a little more detail kind of throughout the case presentation we're going to talk about today, but this is just to highlight what this document is going to look like. And really touches on everything you would need to know from the very beginning to end of PrEP prescribing, from labs to consider at baseline, labs for monitoring, the different formulations and frequency of PrEP, how long it takes until there's protection, FDA-approved indications versus other considerations, harm reduction focus, side effects. So we'll kind of go through this throughout the presentation. Also, this is going to become available to you all in the very near future. So we're going to start with a patient case. So we're in clinic one day, and Z is a 34-year-old person assigned female at birth, presenting to your clinic for evaluation of possible cellulitis of the forearm. She reports ongoing injection drug use of opioids and inhalation of stimulants, and exchanging sex for shelter, although does spend time unsheltered as well. She discloses use of shared needles when she's not able to access the local syringe service program. She originally came in for this arm complaint, and so you evaluate that and discuss an oral antibiotic management plan for her mild cellulitis and wrap that up pretty quickly. But then you also inquire if Z's ever heard of HIV pre-exposure prophylaxis, or PrEP, as you think she could be a good candidate with her risk factors of injection drug use and sharing injection equipment. And she states that she has heard about PrEP from a friend, but doesn't have specific knowledge of how it really works, but may be interested and would like to learn more. So going forward, we're just going to kind of highlight from beginning to end the steps we would consider for PrEP prescribing in a situation like this. So first, we'd obtain a good medical history. So for Z, that medical history includes a history of prediabetes, anxiety, wrist fracture in the past, a history of an opioid overdose, and she had Hep C, but we know that that was treated and have confirmation of that treatment. She's on escitalopram. She had a past surgery for her wrist fracture. She doesn't have a family history that she's aware of since she was adopted. And her physical exam shows some findings consistent with cellulitis, which we're treating her for, but nothing otherwise remarkable. And just to kind of frame the conversation, I know I touched on this in our introduction, but the reason that our presentation is poignant now is especially with the outbreak going on in Penobscot County with HIV cases, which I'm sure many of you are well aware of or actively involved in, but just kind of highlighting the amount of cases that we've had in a county that generally has 1 or 2 new diagnoses per year, and over the last 18 months has had 24 confirmed cases. And since there's a significant amount of folks in this outbreak who struggle with injection drug use and being unhoused, that is kind of a focus of our presentation, the harm reduction framework. So our next step would be determining eligibility for PrEP. And the major thing I want to stress, which I put at the top bullet point, is we really recommend prescribing to any patient who requests PrEP. And I put at the bottom of the slide some more kind of in-depth algorithms from the CDC about PrEP prescribing, but those algorithms kind of end in like prescribe PrEP or discuss prescribing PrEP, kind of regardless of how you get to the end of that algorithm. And so that's really a big takeaway from today, is that PrEP is reasonable for anyone who requests it, in addition to some other folks that we really want to consider it in. So if there's risk of exposure to HIV through sexual contact, this is not an exhaustive list, but some examples could be having sex without 100% adherence to barrier protection with partners, a confirmed bacterial STI, HIV partner who, or a partner who's HIV positive but does not know their viral load, or someone where the HIV status is not known. And then for injection drug use, sharing of injection drug use is a major risk factor. And on the right, we put a table that can just kind of break down the risk a little more in depth in terms of higher risk at the top being needle sharing injection drug use, 6.7 per 1,000 individuals or exposures, and going down to insert of oral intercourse at 0.05 per 1,000. And that can be a helpful thing to talk about with patients if they're trying to assess their risk. For instance, if it's someone who is using injection drugs and sharing needles and might think that a sexual exposure is higher risk than that, but it actually isn't according to the data. So this can be helpful for talking with patients and also just for your own knowledge. And so next we would think about contraindications to PrEP. So there's a few things that are significant contraindications. So someone with a known HIV infection, or if there's a significant concern for acute HIV. So if someone is in your clinic and inquiring about PrEP, or you're talking to them about PrEP, but they had a significant possible exposure to HIV a few weeks ago, for instance, and they're having an acute febrile illness with myalgias and joint pains and other signs of acute HIV, then that would be a reason to reconsider PrEP prescribing. Also, patient weight less than 77 pounds or 35 kilograms, and folks who have had a significant potential HIV exposure in the past 72 hours without symptoms. And the reason why this is a contraindication is because in this situation specifically, we would want to consider post-exposure prophylaxis, which is different than PrEP in terms of its formulation. And with that, I'm going to hand it off to Toby.
Awesome. So I'll review now sort of our next steps. And okay, what do we do from here? We've determined this individual is a good candidate for PrEP. There are no obvious contraindications for this individual, and they're, if not requesting, at least PrEP curious or or wanting to learn more. So let's take advantage of that motivation at this point. So from my perspective, there are three main questions that you need to ask someone to figure out what do we do for them in terms of getting them started on PrEP. We'll walk through each one in a little more detail, but I'll say them out loud now so that you can have them in mind while you as we move through this. The first question is, what does the patient want? What do they prefer? And sometimes we lose track of this as medical providers, so it is important to understand what is the patient looking for from their PrEP experience. Does the patient have certain comorbid conditions, contraindications, or significant medication interactions that we need to consider? And what are some of the logistical barriers for the specific patient in terms of staying connected to PrEP? So Patrick, you can go to the next slide. So the first question is, what PrEP formulation does the patient prefer? And a little bit, what is their indication for PrEP, although I'll complicate that discourse momentarily. So the first question is, which does the patient prefer, an oral option or an injectable option? And so I'll talk about them briefly here. I will also acknowledge that in HIV and like virology, meaning treatment of viruses in general, there are 1 trillion acronyms we use to describe medications, and Patrick has helpfully put in a key on future slides to help you coming back to them. I will try my best to use the brand name so we're all talking about the same thing because they're much more easily understood by talking about their brand names. But so just know there's a lot of F and TDF and TAF on here, and those are all names of medicines. So the first question is this patient open to taking a daily oral medication, or is that feasible for them given their situation? Or are they more interested in a long-acting injectable medication? The oral medications are generally prescribed daily. There are some nuances to that, but for the purposes of today, I would say with ongoing HIV exposures, daily dosing would be the most appropriate use of PrEP. And the two general options we have are both based out of the medication tenofovir, which is a medication used to interrupt infection with viruses. And the first and sort of older medication, the brand name is Truvada, which you may have heard about. The slightly newer approved version for PrEP is called Descovy. There are slightly different reasons why you might use one over the other, which we will discuss. There are two injectable options available. The first is cabotegravir, which the brand name is Apretude. This is an intramuscular injection, which is given every 2 months, which you could understand why it might be appealing to some folks to go to an every 2-month injection as opposed to an everyday medication. There are some logistical barriers to this, but it is a good medicine. It's highly effective, thought to be actually slightly more effective than the oral options, largely because people don't forget to take it because it's a once every 2-month medication. There is a newer medication which is being studied for the purposes of pre-exposure prophylaxis right now called lenacapavir. This is a medicine we use for highly drug experienced folks living with HIV, and sort of it's a newer medicine that we use for folks living with HIV when there are no other options because of resistance for them. However, there's really good evidence that this is an extremely effective pre-exposure prophylaxis medication as well. And this holds great promise because it's an every 6-month subcutaneous option. We expect that this will get FDA approval for use as pre-exposure prophylaxis sometime this year. There are two ongoing trials looking at this. There have been 2 really great RCTs done already for lenacapavir, which show superiority over oral PrEP formulations. The ongoing trials, one of them features folks who inject jugs. So this will be an interesting thing to follow in the future for the population that we're thinking about today. But it is anticipated to be just as effective, if not more effective, than oral options for folks who inject drugs. And so I point out the FDA approved indications here only to say that this is what the FDA has approved. And so we do talk about off-label use of medications in this presentation, and we do it for a few reasons. One, there's good data to support off-label use for many of these medications, and 2, we're thinking in a harm reductive context here. So, and so I will point out that FDA approval is helpful. Although I guess we'll see where that goes in the next few years. But in general, it is helpful. But it does not mean it's not unsafe, that it is unsafe to use some of these medications for non-FDA approved indications as well. So I'll run through them briefly just so you're aware. For Truvada, this is FDA approved for all patients for all indications. And so if you were in a situation where either by protocol, wherever you're working, or if you're looking to go kind of by the FDA approved book, Truvada is going to be a great option for almost all patients who are thinking about PrEP for. Descovy is only FDA approved for folks assigned male at birth, although more recent data actually coming out of the lenacapavir studies would suggest that it is just as effective as Truvada for folks assigned female at birth as well. So we've got a little bit of data to support the use of Descovy in folks assigned female at birth. And it's only been approved formally for potential sexual exposures to HIV, although we know that folks who are exposed via injection use or drug use may also be at risk of sexual exposure as well. And so we take that indication with a grain of salt. Cabotegravir Apretude is approved for all patients for sexual exposures, but similar idea here. We can reasonably assume that folks who are exposed for sexual purposes who also have an indication for injection use may also have a sexual exposure. There's limited data in pregnancy for cabotegravir, but generally considered to be safe. There is a registry ongoing to track possible complications or side effects or teratogenic effects. But if it was the right thing for the patient, it would be reasonable to recommend this during pregnancy. And lenacapavir, we're still getting to understand better in the PrEP context. And it's honestly rarely used in the HIV context as well. But all initial studies would suggest that this is an extremely safe medication that should be viable for all patients for all potential exposures. Okay, next slide. The next question we have to consider is, are there comorbid conditions that would point us in one way or another? Are there contraindications or are there significant medication interactions? There's a lot of consideration about this, and people get tripped up on this sometimes, but so I tried to break it down as easily as I could here. If a patient has osteoporosis or osteopenia, you might avoid Truvada for that patient. There is some data to suggest that it affects bone mineralization. So if the person already has significant decreased bone mineralization, it may not be the right choice to go for Truvada for that person. You might consider Descovy or one of our other options. The next consideration is chronic kidney disease. It is important for our oral options to understand what the creatinine clearance is for the patient. If the patient has clinically significant chronic kidney disease, you likely are going to avoid Truvada for them. And that is mostly because of a toxic accumulation of Truvada, not because it is directly nephrotoxic per se. Similar idea to metformin in that it can result in a sort of a lactic acidosis picture for folks who don't filter it out well. And so you may move more towards Descovy, or the injectables do not have any renal considerations at all. So that might be an opportunity to move towards an injectable. For folks who have a history of chronic hepatitis B, we can use both Descovy and Truvada to actually treat that hepatitis B. The tenofovir that is part of Descovy or Truvada is appropriate treatment for hepatitis B with daily dosing. So there are what is called on-demand versions of dosing Truvada or 211 versions. Again, for folks who have consistent potential exposures to HIV, we wouldn't recommend these on-demand dosings and would go towards a daily dosing instead. And in that case, for this person, if they had hepatitis B, that would be a twofer. You'd be treating their hepatitis B, keeping that under control, and preventing HIV transmission or acquisition, I should say. There are a few medication interactions that are important to know about, and we just recommend running an interaction check for any patient. And the Liverpool folks who also brought us our COVID-19 interaction checker also have an HIV medication interaction checker. So it will be included in the materials that Patrick and I send out at some point. But if you simply Google Liverpool HIV drug checker, you can check against the medications folks are on. There are a few key ones to know about, and it's mostly anti-epileptic drugs, AEDs, and rifampin. Often cause problems for a lot of different medications, and it is true for particularly cabotegravir and lenacapavir. Theoretically, also true for Descovy as well. And it lowers the serum doses or concentrations of those medicines. So it may make people more likely to acquire HIV and less protected. And so that is an important thing to know about. For lenacapavir, there is a theoretical chance of increasing serum opioid concentrations and antipsychotics, which may be relevant to the population that we're thinking about in terms of folks who are using opioids or on opioids as part of treatment for opioid use disorder, or on antipsychotics for mood-related reasons. This is also true of DOACs. Some of our blood thinners you can increase serum concentrations of that. So there's a little bit of a theoretical consideration around this that would be appropriate to check in with your patients about, and you might have a thought or two about that before moving forward with lenacapavir for these folks. Next slide, please. The next thing to think about is what are the logistical barriers to PrEP adherence, meaning how do we keep this person on PrEP if they're going to be consistently exposed to HIV and at risk for HIV? And we already talked about one of them. It's this idea of daily dosing versus long-acting injections. You can expect that many people will find some appeal in a long-acting injection versus a medicine they have to take every day. There are follow-up visits particularly for the injections for cabotegravir or Apretude. That's an every 2-month injection. So you need to be able to locate that person every 2 months, which may or may not be reasonable depending on their situation. There are some models where cabotegravir or Apretude is brought out to people, which is a great model for folks who maybe have a hard time coming into clinic. So that might be a workflow to consider. Lenacapavir will be less frequent, 6 months in between, but sometimes folks can get lost to follow-up without frequent follow-up, those frequent visits. So getting people in every 6 months can also be a challenge for somewhat different reasons. People sometimes move on, forget, are in a different place altogether, and may not be able to access their medication. Cost is an important consideration. For right now, PrEP is required to be covered under a grade A recommendation from the United States Preventive Service Task Force. But of course, this is being heard was just heard in the Supreme Court. So we will see if this continues to be covered by insurance plans moving forward. I will say Truvada is available as a generic medication. So even without insurance, this is the most affordable option. And I think it comes out to like, I don't know, last time I checked for a 30-day supply, was it like $10, $15 or something like that? So it's not nothing, but it's not as much as some of the other medications out there. And then there are considerations around discontinuing these medications as well, which we'll talk about here in a second. Next slide. So I want to talk about harm reduction considerations for each of these medicines here. I've got a few asterisks in here to provide some nuance to what's going to be on the PrEP starter kit sheet that we'll hand out to you all. I want to start by saying all patients deserve the standard of care. That is true, and we should do everything we can to get them the absolute standard of care that we can. And we also know that for some individuals, it is hard to maintain a very frequent screening regimen, a very frequent office visit regimen, and we do our best for those patients. Acknowledging that preventing HIV may be more important than getting every single lab every single time. And so that's the asterisk there. Across the top are the names of the medications. From left to right, we have Truvada, Descovy, cabotegravir, which is Apretude, lenacapavir, which under its current brand name is Sunlenca, but will get a new brand name once it's FDA approved for PrEP. And in each column, we have a few considerations here. So in general, we really love getting rapid HIV testing at the time of renewing somebody's PrEP prescription or giving them their next dose of medication. That's to see if they have HIV. There are cases of breakthrough infection. This is true. Typically, for oral meds, that comes if folks aren't able to take their oral medication consistently. At least 4 doses of an oral PrEP option will get you at least 90% protection against HIV transmission. That's pretty good, 4 doses a week. However, if you start dropping below that, you get less and less protection. So we like to test people for HIV before renewing prescriptions for them or giving them their next dose of an injectable. And we love getting serum tests as well. That is a sort of the gold standard would be to do that. If you have point of care rapid HIV testing, which is a 4th-generation HIV test, which tests for both antigen and antibody of HIV, that is a reasonable thing to accept in terms of proof of not having HIV and moving forward with prescribing. Ideally, obtaining a serum sample as well for confirmatory testing. That would be the gold standard. So it should be offered every time. If you have something other than a 4th-generation point of care HIV test, that would be less exciting to accept before moving forward with PrEP prescribing, but could still potentially be done as long as there is a plan to, at some point in the near future, obtain serum testing or a 4th-generation test for that patient. If you have something less than a 4th-generation point of care test, it would be reasonable and probably encouraged to consult with somebody who's pretty experienced in prescribing PrEP to help you through that. One thing to point out for all of our formulations of PrEP is that there is a conception out there in the world among our trans and gender diverse folks on gender affirming hormone therapy that HIV medications interfere with the levels of gender affirming hormones in their system, which for some people is actually a huge barrier to engaging in HIV treatment for one, but also is a barrier to engaging in thinking about PrEP as a good option for them. And so you can reassure your patients that none of our medications that we use for PrEP interferes with their gender affirming hormone levels. This may be a way to help that patient engage in taking PrEP if it's right for them. Okay, so we talked about, in general, point of care testing and gender affirming care. We talked about Truvada as coming as generic. That's a cost saving harm reduction measure. For Descovy, it is reasonable to consider using Descovy off-label for folks who inject drugs as their primary risk factor for HIV. We suspect it's going to work just as well as Truvada. It is reasonable to consider Descovy for people assigned female at birth. As we talked about, there's some decent data showing equivalent efficacy between Truvada and Descovy in folks assigned female at birth. And just to note, Descovy does not come as a generic right now. And so sometimes people really want Descovy for one reason or another, and it may not be available to them because of the cost. So just know that that's true. Cabotegravir, again, we have not studied it formally yet in folks who inject drugs, but we have no reason to expect that it won't be just as effective. There is sort of an old protocol out there that recommended a 30-day oral lead-in of oral cabotegravir before putting somebody on injectable cabotegravir. That is no longer recommended. That now, if you were to do that, sometimes we might do that if someone is worried about an allergy to cabotegravir for some reason. You might trial an oral dose first before a 2-month injection. But in general, there's no need to do an oral lead-in to cabotegravir at this point. You get to the same protective levels very quickly. In terms of wiggle room around when do you give the next dose, there are a few different thoughts about this. If you look at the prescriber information, it will say plus or minus 7 days from that 2-month period before needing to reload. So there is a loading dose for cabotegravir. You give the first dose of an injection, 1 month later you give a second dose, and then from then on it's every 2 months. If you talk to our pharmacists here, our HIV pharmacists here at Maine Health, they would say you can go as long as 3 months since your last injection before needing to reload. So that would be a month late for the next injection. So there is some wiggle room there, but if you're getting past 7 days after they're due, that's a risk-benefit conversation with that patient about reloading versus not. And we'll talk a little bit more about that in a moment. Importantly, for folks who may have gluteal fillers, meaning they inject silicone or other things into the gluteal muscles for a variety of reasons, but this is not uncommon out there in terms of folks who are trying to get a fuller appearing gluteal region. These are gluteal injections, and so putting a cabotegravir into a gluteal filler will make it less effective, and so it is not good for that patient, unfortunately. And then with lenacapavir, as we mentioned, currently off label, but there's really good studies out there showing excellent efficacy in preventing HIV. We have got a plus or minus 2 week timing in the official prescriber information here before needing to reload. Lenacapavir is kind of interesting. Instead of having close together injections up front to load, we actually give a dose of oral lenacapavir the day of injection and the day after injection. And that's the way you load lenacapavir. And then after that, it's every 6-month injections. So there's a little bit of nuance there, but I would say if you're getting outside that 2 week window for the next dose, you would want to think critically about what is this person's relative risk of HIV exposure and should we reload them or not. For lenacapavir, it is reasonable to opt for every 6 months HIV testing. Ideally, we test before every time we get a new prescription out, which for most of these is every 2 or 3 months. That would be the ideal. But given lenacapavir only requires every 6-month appointments, it's not unreasonable to think about every 6-month testing, and you would test ideally before giving the next lenacapavir injection. Okay, next slide. All right, discontinuation considerations. This is busy at the bottom, but I'm going to try to boil it down to you on the next slide, so bear with me. So for Truvada and Descovy, these first 2 columns here, we mentioned that the tenofovir component of these options for PrEP are treatment for hepatitis B. And so folks who have hepatitis B, chronic hepatitis B, if you were to stop that tenofovir, meaning you stop the PrEP, they have a risk of having a flare or a reactivation of their hepatitis B. And so that's not necessarily a reason not to stop if they really want to stop, but you need to have a conversation with that patient about if we stop this tenofovir containing medicine, your Descovy or your Truvada, your hepatitis B may flare, and that may put you at risk for liver failure. What we do is talk to the patient about their goals around their liver health and their hepatitis. And if they really want to stop their tenofovir-containing medicine, we monitor for reactivation with an AST and an ALT. If those start to elevate, then we go further and test for hepatitis B DNA to see if their viral load is increasing. For cabotegravir and lenacapavir, so we have kind of a complicated pharmacokinetic consideration to take into account with these long-acting injectable medicines. And I'm going to explain using the simplified diagram on the left, and then I'll tell you a little bit more detail on the right here. But in general, the thing that we think about if someone really wants to stop taking these long-acting injectables, or if they are not available to get their next dose, we worry in a theoretical way about some amount of that medicine, cabotegravir or lenacapavir, being in their system for some amount of time, but in a subtherapeutic amount, meaning not high enough levels to prevent HIV, but still hanging around in the body. We worry about this because, again, theoretically, if HIV were to enter the body and there was a little bit of cabotegravir or a little bit of lenacapavir, in theory, that could create a resistance in that strain of HIV to cabotegravir or lenacapavir. You've got a little bit there, but not enough to control the virus. And so for some people, this can feel like a real barrier to prescribing these medications for folks if you're not feeling 100% confident that you're going to be able to see them every 2 months or every 6 months, which is an understandable concern. But I'm going to walk you through why, from a harm reductive standpoint, we might consider still prescribing, even if we're worried about follow-up. The standard of care for someone on cabotegravir or lenacapavir, if they wanted to stop taking that medicine for PrEP purposes, would be to recommend going on oral PrEP after they stop the injections, when they would be due for their next injection. The idea is you want to maintain some amount of protection against HIV while the cabotegravir or lenacapavir makes its way out of the body. That is important if they have potential ongoing exposures to HIV. If they are stopping because they don't have any more exposure to HIV, they do not need to switch over to an oral PrEP option because they don't have any potential exposures to HIV. How long to keep someone on oral PrEP after they stop an injection is an area of discussion, and it is all based on the pharmacokinetics or how the medicines work in the body. And so this is this more complicated graph in the bottom right, which I'm going to spend like 2 minutes on, maybe 3, and I don't want you to get too lost in it. But these blue lines here show the level of cabotegravir or Apretude in the body. All the way to the left is 1 week after injection. All the way to the right is 76 weeks after injection. The red line across is the therapeutic level that we ideally would get to prevent HIV. This first yellow line is at 8 weeks when someone would be due for their next injection. And you can see, even at 8 weeks, or like just after 8 weeks, around 12 weeks, some people start to dip below this therapeutic level, but they still have some cabotegravir in their body. You go out to 24 weeks, that's almost half a year-ish. You see even more people have some cabotegravir in their body, but not enough to prevent HIV. You go out as far as a year, 52 weeks. Some people still have cabotegravir in their blood, but not enough to prevent HIV. And so we think about this and we consider it, and we do the standard of care and offer and talk to our patients about this potential risk. We offer them oral PrEP and let them know that if we can't get you your next injection, or if you want to stop, we would recommend going to an oral option. But you can go to the next slide, Pat. But I would say, in general, from a harm reductive standpoint, don't let the theoretical risk of HIV resistance in these folks limit your ability to prevent HIV today. Okay, so these are excellent ways to prevent HIV. And if the person is ready for an injection and that's the way that you're going to get them HIV prevention, it is extremely reasonable and defensible to still give them that medicine, even if you're not quite sure if you're going to be able to see them again in 2 months or in 6 months. And I put this chart next to it here, which is sort of all of the medicines we have to treat HIV right now, should the person develop HIV and should the person have a resistance to cabotegravir or lenacapavir. We have a lot of options to treat HIV. And what I would say is just because a resistance to one may be developed, which again is more theoretical. I don't know that we've really seen this in practice yet. Doesn't mean we don't have great options to treat HIV for this person in the future. So again, I'd rather prevent HIV now than not prevent HIV with the off chance that someone has a very rare event in the future. Next slide. All right, baseline labs. These will be handed out to you in the future, but all of these baseline labs should make sense based off of the things that we talked about today. So for Truvada and Descovy, and for all of these medications, we want to know what someone's HIV status is, ideally before we prescribe them HIV or prevention medication, although put an asterisk on that. If you can have a point of care rapid test before you prescribe, that's awesome. For Truvada and Descovy, you want to know what their hepatitis B status is. And that's because the tenofovir in those medicines treats hepatitis B. And if they have hepatitis B, one, we can treat it with Truvada, Descovy. That might be a reason to choose those medicines. But if they stop, their hepatitis B could reactivate, and that would be a problem. We want to know what their creatinine clearance is for the reasons we talked about earlier. Those, I would say, are the essential labs to obtain for these medicines before starting. It would be also nice to think about grabbing the other labs down below, which would include STI screening, so gonorrhea, chlamydia screening, and we recommend 3-site screening. So we recommend oral, rectal, and either vaginal or urine collection or testing for gonorrhea, chlamydia. We recommend serum testing for syphilis. We recommend testing for hepatitis A, and honestly, hepatitis B for all people, to look for opportunities to vaccinate. And we recommend hepatitis C screening as well for opportunities to treat. We know in the cluster here in Penobscot County, I think it was 22 out of 24 folks diagnosed with HIV also had co-occurring hepatitis C. And so this is an opportunity to treat that as well. They often travel together, called syndemics. And then it is helpful to test for pregnancy. I will say that Truvada, Descovy, cabotegravir are all thought to be safe in pregnancy and would be reasonable to continue those things throughout pregnancy. Lenacapavir, I think we still need to understand better. Wouldn't be a reason to stop these medications necessarily, but it would be an opportunity to link that person to support. Okay, next slide. However, you don't need to delay PrEP prescribing for the sake of obtaining these labs, unless you have a very strong suspicion that someone has advanced kidney disease because of comorbid conditions or something of that nature. You might want to see that creatinine clearance before you prescribe, or you might move towards an injectable. You might move towards Descovy. Ideally, you'd have a rapid HIV test at least before starting one of these medicines. But what I would say is if you can work out a consistent way of getting in touch with this individual, should an abnormal lab come back, it is reasonable to proceed with prescribing PrEP for that person. Ideally, we see people a month after we start PrEP for a follow-up visit to review labs. So getting that scheduled before the person leaves might be a great way to just like have that in place. 1 month of PrEP for someone who maybe has HIV is not the end of the world. We can get them started on antiretroviral therapy for full treatment of HIV within a month. That's still reasonable. So again, if people are ready for PrEP, we try to get it. We try to get them PrEP whenever they're ready for it. Okay, next slide. And so we'll conclude this case here. This patient opted for cabotegravir injections, which is great. They were open to a rapid fourth generation test. It was non-reactive. Our clinic happens to stock cabotegravir, so we just administered it that same day. Clinics generally don't stock cabotegravir, so that's a workflow issue for getting cabotegravir into people. You often have to order it from a pharmacy and then administer it. So there are different ways to go about that. And Pat and I are certainly not the experts on that, but there are models out there that stock these medications on site. The patient was open to phlebotomy that day, so we got all of our baseline labs, which was great. We offered STI screening. And we talked about other opportunities for prevention, including vaccinations, doxy-PEP, which is providing doxycycline for folks after sexual exposures to prevent chlamydia and syphilis, and maybe a little bit gonorrhea too. Although asterisk here is not well studied in folks assigned female at birth, so there's some nuance there. But we talk about these things with these patients. We talk about SSPs, we talk about safer sex supplies, among other ways to prevent and maintain health. And we got a bunch of ways to contact the patient for lab and medication follow-up, and we scheduled them for a 1 month follow-up as well. Next slide. They came in for their 1 month follow-up. Or maybe we went to them. I don't know. There's a lot of innovative models out there. We did another rapid test, which was non-reactive, which was very reassuring against active HIV infection. We gave them their second dose of intramuscular cabotegravir, and we've completed their loading dose. And the baseline labs revealed an opportunity for Hep B vaccination. So we offered Hep B vaccination. We got 1 dose into them that day, which was great. Next slide. 2 months later, the patient's loving their cabotegravir, but now they're not consenting to phlebotomy for their serum HIV antigen antibody test, which again, they're consenting to a rapid. It's non-reactive. I'm still going to continue and move forward with giving them that cabotegravir IM dose, and I'm going to make a plan with that patient to how to support them to getting serum testing in the future. And it's a reality. Phlebotomy is hard for a lot of reasons for a lot of people. And is it ideal? No. But if you have a good point of care rapid test, you can feel pretty confident in that test being real. We offered our second HPV HEPLISAV dose, and the patient declined, unfortunately. But we're going to keep working on it because that's part of this journey. Next slide. Okay, they're at 6 months, 2 months later for their next dose. Rapid test negative, and oh, look, we worked really hard with this patient, and now they're ready for a serum HIV test, and we're going to draw that, and that's part of the ongoing relationship. And we're going to talk about how do we keep this going in the future. And we're going to give this second dose of HEPLISAV now, and we're going to get them fully vaccinated against hepatitis B, and that's an ideal outcome. And that's part of the journey, walking through this with patients. Next slide. So again, just to recap, this will come out your way. We should have a few final tweaks to it, but this is a document we developed that's supposed to serve as basically a one-stop shop for getting people on PrEP and also helping them maintain PrEP access. And the hope is that we'll limit some of those just like logistical barriers or like harm reductive barriers to get more PrEP in more people's hands. At Gilman Clinic, which is the sort of like HIV hepatitis clinic in Portland through Maine Health, we always welcome folks calling if they just need to check in with someone about, am I doing this right? And this is also part of this process too, is creating a network to support people in prescribing. So that this information will be available to you as well this phone number and fax number if you want to chat with someone. Next slide. And three other spots you can go on the internet to talk if you want to learn more about PrEP. So the AIDS education training centers are a great place to get more education and materials around this, and they have a very nice quick guide, which is a little bit similar to ours, however, does not include some of those harm reductive considerations and does not have lenacapavir on it, but is a great resource nonetheless. Um, and the National PrEP curriculum is a very in-depth curriculum about PrEP prescribing. I will say that is run through HRSA and the CDC, so a lot of things were scrubbed from it, unfortunately, and people were erased from this, unfortunately, with the change in administration. So take that with a grain of salt. But the information is generally still accurate and good from a medical perspective, just omits a large number of people. And then the CDC has pre-exposure prophylaxis guidelines out there, which have been moved to the stacks, as you can see, which still maintains a pretty good representation of folks who qualify for PrEP and some of the nuances there. Um, and so, um, and so feel free to reference those, but also know that Patrick and I and also Dr. Rawlings are very available for consultation if you're looking for some help. Next slide. And so we'll stop there. I think that's what we have today. We welcome questions, thoughts, reflections at this point.
Thanks, Toby. And I just wanted to reiterate something that Toby had highlighted that I think he did a really good job of. There's kind of like, the ideal perfect situation in the clinical settings that we hope for, but knowing that we all exist in reality, and some of the alternative options, for instance, like having a rapid test instead of a serum test, that is still a very good option. And, ideally we want to have a serum HIV test in the long term for folks on PrEP, but thinking about like, is this still a good option? And I think that mindset can really change things from a prescribing lens. So I think thanks for doing that, Toby. You did a great job on that. I know I saw the chat going off, but I haven't looked into it yet. So
These were helpful pieces of info from Casey. So, and then
okay.
one note from someone at Northern Light saying they've integrated a component of like help with PrEP prescribing into their electronic health record, which has been really helpful for people
Oh,
in
very cool.
navigating monitoring and prescribing.
Any major questions?